Thank you very much, Professor Rohit, and to the program committee for this honor. As you quite rightly say, my journey in ophthalmology started in India, and it's a real honor to be back. I'd also like to thank the speakers who've come before me. We've had some excellent talks today and some fantastic videos, and a lot of what I say will build on what's already been talked about today. I'm told that I'm sandwiching a session between basic and more complex strabismus, and I cannot think of any topic better to do this than concomitant strabismus. So can you just see if this doesn't seem to be moving? So concomitant strabismus, very simply, is a strabismus that's different in different directions of gaze. You can see here a patient who has a bit of an exotropia in straight gaze, which is more in right than in left gaze. So the definition might be simple, but managing these patients is very challenging. Why? Because the deviation is different in different directions of gaze. So even before you start doing anything, you have to adjust the expectations very, very carefully. And the second reason why these patients are challenging is doesn't seem to be moving. Can you see? My talk doesn't seem to be moving. Okay. Oh, you can move it for me. Great. So, and the other thing is the causes of concomitant squint always raise a red flag. So an acquired concomitant squint needs to be investigated. Is it a neurological problem, or is it a mechanical limitation because of thyroid problem or myasthenia? You have a few congenital forms of concomitant squint, but a lot of these squints are acquired and need to be investigated quite carefully. So I have a strabismus theatre every Monday morning, and before this, me and my fellow registrar have a little talk about what we're going to do. And the most amount of questions are about concomitant strabismus, which muscle, which eye, how much. And over time, I developed a few rules which I think help me. Now, like all good rules, they're meant to be broken, and I break them on a daily basis, but I think they will serve as a basis for discussion. So can you have the next slide, please? So just a little bit of revision for the more junior members. These are the muscles that move our eyes around, and every time you make a movement of both eyes, a yoke muscle pair comes into view. So if we can we have the, so when you look to the right is the right lateral rectus and the left medial rectus. That can we just have the no, that's fine. I've got the pointer. So when you look to the right is the right lateral rectus and the left medial rectus at work. So that's extroversion. Do you mind just going next? Yeah, next. And when you look up and to the right is the right superior rectus and the left inferior oblique. Now we'll come back to the diagram again during the course of this talk. Next slide, please. So I insist on 9-gaze measurements for a lot of my patients, much to the dismay of my orthoptist. So here's a 9-gaze measurement, which basically shows the concomitant squint. The deviation is almost the same in all directions of gaze. Next, please. But here you see the situation is a little bit different. This is a patient that also has an esotropia, but it is much more on the right side. And next, please. So next, so going back to our diagram, so which are the two muscles that work on the right side? Well, the right lateral rectus and the left medial rectus. So therefore, there must be a problem either with an underaction of the right lateral rectus or an overaction of the left medial rectus, or both. So, next, please. Next. Next. So by using this, all of this information we have, we conclude this is a right lateral rectus underaction or a right sixth nerve palsy. So you can use the 9-gaze and your knowledge of anatomy not only for the diagnosis but also for the management. Next, please. So here's the patient. Can you click on it, please? So here's the patient we were talking about. You just click on the video. It should start playing. No, just go back, click on the video. Just go back and you can click on the, do you want me to do it? Yeah, there we go. Just click on the video. This is the patient we're talking about. So you can see he has a right esotropia. I'm going to ask him to look to the right, very little lateral rectus function. So this is the patient we're talking about, a patient with a right sixth nerve palsy. Now, what can we do for him? Well, the first thing is, this is an concomitant squint. His deviation is much more in the right gaze. Second thing, we know he has a head turn to the right. Next, please. So here's my first rule. If you're going to do anything for these patients, target your direction of gaze where the deviation is the most. And why do you want to do this? Well, this is a binocular field of single vision, which I find very, very useful. You can do this on on any octopus perimeter, and you can see the whole right side of the field is diplopic, including the fixation point. So this crescent here is the only place where you see single thing on the left. So what you want to do, you want to move this to the center to eliminate his head turn. How can you do that? Well, if you have some lateral latus function, you can do a recession of the MR. But if you have no function at all, if there's a dead muscle, you have to use a neighbor. Next, please. And this is what, so you can do a transposition, you can do a full tendon or a split tendon or the Nishida procedure. All of them have their own proponents. For this patient, next, please, I used a crouch procedure. I like this very much because, as one of our speakers said, you really don't want to do more than 2 recti at one time. Using this procedure, you just move the superior rectus to the lateral rectus, put in a posterior fixation suture, and you recess the medial rectus on an adjustable. So you're just using 2 muscles, but you have a safety net of a recession, and you have a very, very powerful abducting force. Next, please. Can you just click on the video? And this is the same patient I showed you at week 4. And you can see now, the eye has settled, and you can see he's actually a little bit exophoric. I'll just show you the ocular motility in a minute. You'll see just by using 2 muscles, you've given him quite good ocular motility. Now, note he still doesn't have full abduction, and you have to warn these patients in incompetent strabismus. You are not, you're not chasing perfection here. Next, please. Also be very aware of the secondary effects of your surgery. So every time you recess a muscle, you get an effect in primary position. But when that muscle works, you get an augmented effect when in the direction of action of that muscle. And these effects can augment or detract from your intended aim of surgery. And it's best to be aware of them so you can actually use them to your advantage. Next, please. To give you an example, in this case, we did a right, we improved the right abduction. Okay? But what you could have done, you could have weakened the left medial rectus. Now they would have given you an improvement in primary gaze, but when this patient looks to the right, you get a secondary limitation of or weakening of this muscle, causing a further collapse in this angle here. So that would have been something else you could have considered. Next, please. My recessions on the whole are hangback because I do a lot of teaching and training, and I find it's very easy to train residents on these because you're doing all your suturing here, where you have better exposure, and also then you can use this with an adjustable suture. Next, please. So here's my second rule. You try and target the muscle that move the eye in the direction of maximum deviation, if at all possible. Next, please. So I'm going to show you this video. You can go to the next. So this is a 30-year-old. Can you click on it, please? A 30-year-old who came to us because he had vertical diplopia for as long as he could remember, and he was now finding it difficult to read. So you can see this is primary gaze, looks to the right, and you can see quite marked left over right. Okay? So this very clearly is a left fourth nerve palsy. It appears to be congenital because it's quite a large deviation. When it looks to the other side, there's hardly any deviation at all. Next, please. So this is now the 9 gaze. It's a little bit more complicated here. Why? Because there are 3 measurements. The top one is the horizontal, this is the vertical, this is the torsion. And you can see this patient has 3 kinds of strabismus. Okay? So how do you go about deciding what to do in this case? Next, please. The first thing is to see, well, where is the deviation the most? He's got a lot of exocyclotorsion in down gaze, and he's complaining, next please, of difficulties in reading. Also, he has a left over right, much more in dextroversion as you would imagine, but also much more in down gaze. So based on this, next please, we started to do, okay, next. So in dextrodepression, the 2 muscles that work are the right inferior rectus and the left superior oblique, and based on the exocyclotorsion and everything we talked about, we decided to do a superior oblique application procedure. Okay, next please. Next. Just click on the video, please. So what you can do is before you start, you can do an FDT. So here I'm pushing the eye up and in, and you can see because of loose tendon, you can really push the eye in and get a very good idea of the laxity of the tendon. You do a superior oblique tuck, and you see post-tuck, you have induced a Brown syndrome, and this is what you're aiming for, really. Next, please. What you want next? So what you want to do is when you finished your tuck, is you need to be able to push the eye just above a line joining the medial and the lateral canthus, giving you an idea of the completeness of your procedure. Next, please. This is the next example. This gentleman came to us for a retinopexy in the left eye, and he had a local anesthetic injection for that. Next, please. And we found out after the injection, the left eye would not go up. Next, please. So this is the deviation. So he's got a right over left, more in up gaze here. So why did this happen? Well, We all know about the myotoxicity of local anesthetics. If you get an injection within a muscle, next please, the bupivacaine can cause selective destruction of the myofibrils, and once they're destroyed, they regenerate, and it leads to you can see this pre and post, a big hypertrophied muscle, and this is now pulling the eye down. Next please. So, and you can please click on the video. So, and you can see now on a force reduction test, this is me pulling the eye up, and this is me pushing the eye down. So you can see I can push the eye all the way down very easily, or you try and push the eye up and you will feel the resistance. So an FDT is a really important test when it comes to managing these cases. Next please. So once we knew there was a restriction, that's what we did. This is my third rule, is a restriction or mechanical limitation, introduce it if at all possible. Okay, just one more to go. This is the last case. This is a patient, quite complicated. He has thyroid eye disease, as very evident. He's had bilateral decompressions and bilateral infectious recessions. His problem is very simple. He sees double when he looks down. Next please. And this is the problem. So he's got a right over left in down gaze. Now, okay, it would have been a very simple thing to do a recession of the left inferior rectus to match this limitation, but it's already been recessed. So what can you do? Next please. You can do a retroequatorial myopexy or a Pardon's procedure. The advantage of this procedure is what you're doing is you're attacking the muscle to the globe behind the equator, reducing the movement arm. So there's no effect in primary gaze, but every time the patient uses this muscle, you'll get a selective weakening. Next please. An alternative is you could do a Scott's procedure, which is a combined resection of the same muscle, so you get the exact same effect. Next please. But it can be adjusted. You can do an adjustable. Next please. And this is my last rule. Okay, if it's not possible to release a limitation or restriction, aim to match it in the contralateral eye if the patient will let you. Next please. And this is the summary of everything I've talked about. Incompetence strabismus is a surgical challenge. You need to counsel these patients properly. Target the muscle to move the eyes in the direction where the deviation is the greatest to center the binocular field. If you feel there's a restriction, try to release it. If you cannot release it, try and match it. Next please. Thank you very much for your attention.